As far as the investigations for the hernia diagnosis are concerned, apart from a hiatus hernia, which requires a gastroscopy, that is an internal hernia which gives us heartburn and reflux, the other hernias which are external are obvious and one can diagnose those on clinical assessment in the clinic. Normally in the United Kingdom, once diagnosis is done, we would proceed to surgery. In Dubai, we tend to get the ultrasound, which is mandatory by the insurance companies to assess the hernia. Ultrasound done as a soft tissue scan is very helpful to identify the hernia, its size and extent. There are other methods of diagnosing some difficult hernias, but those are generally not required. But all the facilities are available to assess the hernia if there was any issue about its different diagnosis. Once the scanning and the testing is done, the discussion goes on about how best to treat the hernia. Wait and watch is one option which should be considered. Depending on the symptoms, the urgency of the hernia repair can be discussed as well. And another aspect that is very important is how to repair the hernia. There are a few choices to repair the hernia. One of the commonest and traditional choice was repairing the hernia with a mesh with an open technique, where if we were repairing an inguinal hernia, an incision of about 7 to 8 centimeters is made on the top of the hernia. The skin and the fat is divided, muscles are divided, and the hernia is isolated and pushed back into the abdomen. A mesh or a gauze, a polypropylene gauze, is placed there which is permanent and becomes incorporated in the scar tissue. All the layers are closed, and that's the way to perform the operation. This side of surgery can be done under general anesthetic or can be performed under local anesthetic as well if we were repairing only one-sided hernia. However, if we are repairing both groins, then generally it's not recommended to use local, because the amount of local anesthetic that we'll be using will be in excess of what is safe level of dosage for the patient. In those instances, the patient has to have one side operated at one stage and come back after a few weeks or a month or two for the other side to be operated. However, if they wanted to get both the hernias operated simultaneously with an open approach, then this can be performed under general anesthetic. However, this is uncomfortable as well, and a patient may need to stay in the hospital for a day or two, and the recovery is a touch slow. The other way, which is a modern way of operating inguinal hernia, is to repair this with a keyhole approach. This can be done with two methods. In one method is transabdominal preperitoneal repair, where a small cut is made and a port or a small tube is inserted into the abdomen and a camera passes through, and then two other ports, 1 centimeter each, are introduced, and the whole of the tummy from inside is viewed, hernia is seen, hernia is retrieved back into the abdomen, whether it's gut or omentum going into the hernia. Then the inside lining of the abdomen, peritoneum, is separated from the muscles from inside. First it's cut open, then separated, and a mesh is laid, interposed between the peritoneum and the muscles, secured in its position, and then the peritoneum is closed on the top of the mesh so that no part of the cut will come in contact with the mesh. And that concludes the operation. The recovery is good and much quicker than an open approach. Since mid-90s, another approach to hernia repair came into vogue as well, and that is called totally extraperitoneal hernia repair. This is probably the most modern version of hernia repair, and this involves making 3 small cuts in the midline below the belly button. One tends to separate the muscles and just goes deeper to the muscles but does not penetrate the inside lining of the abdomen, the peritoneum. And one creates a space either with a balloon or with other techniques within this space and separates the peritoneum from the inside of the muscles. So generally the principle of this operation is not to cut the peritoneum but just to peel it off the muscles. Hernia is reduced, all the bowel content of the omentum is pushed back, Space is created, a mesh is placed between the muscles and the peritoneum and secured, and that concludes the operation, because one does not need to close the peritoneum as one had not opened this. It provides excellent results, quick recovery, and is recommended by NICE, National Institute of Clinical Excellence in the United Kingdom. One-sided hernia can be done as a day case, but even both-sided hernias can be done as a day case as well. Recovery is by far the best with this approach. Return to activity like walking, mild exercise or work at home, return to driving when one is pain-free, return to exercise, and return to work is much faster with this approach than any other approaches.